Okay, so here's where we left off, and then these next slides describe the pathophysiology in a graph form. For example, here are the etiologic factors, or the things that can cause pancreatitis, listed here, and we kind of went over those. Any of those can cause obstruction or direct toxic injury to pancreatic cells, causing the pancreas to produce and release its pancreatic enzymes. Then if you look here, you see trypsin, and actually you start with trypsinogen, which is inactive. It's produced by the pancreas, and normally it's released into the small intestine, and in the small intestine, trypsinogen becomes trypsin. In pancreatitis, the trypsinogen is activated in the pancreas, where it digests the pancreas and activates other proteolytic enzymes, such as elastase and phospholipase. So if you look at these other enzymes, you can see that elastase can cause necrosis of blood vessels and ductal fibers, leading to hemorrhage. The phospholipase A causes fat cell necrosis, and you know your cell membrane is made of lipid-type solutions, which is, well, solution's not the word, but lipid-type substances, and those are fats, and so that can cause cell membrane disruption. Lipase causes fat necrosis, and then kallikrein can cause edema, blood vessel permeability, smooth muscle contraction, vasodilation, and is implicated in shock. Now the next slide that we look at, this one is the one that you see in your textbook. Again, you have your etiologic factors causing activation of pancreatic enzymes, injury to pancreatic cells, and then you have the autodigestion of pancreas from these pancreatic enzymes. Trypsin producing edema, necrosis, hemorrhage, elastase also causing hemorrhage, the phospholipase A causing fat necrosis, lipase causing fat necrosis, and then the kallikrein causing various actions that can lead to shock. Now just what alcohol has to do with it is not really clear, but it's thought that it may stimulate secretion and excess production of hydrochloric acid. That decrease in gastric pH can result in the release of that hormone called secretin, which stimulates pancreatic secretion. It can also cause regurg of duodenal contents into the pancreatic duct, resulting in inflammation. Again, it's not real clear what it is about the alcohol, but these are some of the things that are speculated, and a lot of research has gone into this. The most predominant symptom of acute pancreatitis is abdominal pain. It tends to be in the left upper quadrant. It may be in the mid-epigastric area, but it's often common that it radiates to the back because of the retroperitoneal location of the pancreas. This pain is severe. It involves the upper abdomen. It's unrelenting. It radiates through to the back. Any edema, inflammation, or enlargement of this retroperitoneal organ will cause the posterior peritoneum to stretch over the mass, and that produces the pain. It's a severe pain, deep, piercing, steady. It can be aggravated by food and or by alcohol. The abdomen is tender to touch. It's not relieved by vomiting. It does seem that sitting up and leaning forward lessens the pain. Flexing the legs, especially the left leg, may help relieve some of that stretch. I think I mentioned nausea or vomiting. Diaphoresis, pallor, severe weakness, anxiety. These can be present in severe cases. The patient can get profoundly dehydrated with the associated symptoms. There may be a low-grade fever. This Gray-Turner syndrome is a bluish discoloration of the flanks. This is where the pancreatic enzymes are actually leaking into skin tissue, and this is a pretty severe case, leaking into these skin tissues, causing the cell membranes, the blood vessels to be disrupted, and you get bleeding into the area. Cullen's sign is shown here. That's a bluish periumbilical discoloration. Here this is because of seepage of blood-stained exudates from the pancreas into this area. If there is biliary obstruction, then jaundice may be present with the acute pancreatitis. The serum amylase may be elevated 2.5 times normal within 6 to 12 hours of onset, and it can stay up for several days. Normal is 0 to 125. It's not uncommon to see serum amylase levels that are higher than 200. Amylase is supposed to facilitate carbohydrate digestion, and it's a great enzyme to have in the right places. The lipase is also elevated. It can stay elevated for a couple of weeks. It's more specific than amylase because amylase can also be found in other organs, and for example things like mumps or an ectopic pregnancy, cerebral trauma, bowel or gastric ulcer perforations. These things can also increase serum amylase levels. Renal transplantation can make the amylase levels go up. So there's some other things besides just acute pancreatitis that can affect amylase, whereas lipase is more sensitive to that. Urinary amylase is elevated more often and stays longer elevated than does serum amylase. That's another diagnostic finding. Some other lab abnormalities to consider. Hyperglycemia. The elevation in glucose is probably going to be due to release of glucagons. Although, if the islet cells are damaged, the elevated glucose could be due to a decrease in insulin secretion. Usually it's the glucagons that are affected. Hyperlipidemia occurs because of release of free fatty acids by lipase. So lipase does some digesting and releases these free fatty acids. Hypocalcemia, this occurs because of saponification, where digested fats kind of act as a sponge. You have the digested fats in the abdominal cavity that kind of soak up calcium. But there are some other factors also that are considered to be part of the hypocalcemia that is noted in acute pancreatitis. The hypocalcemia can be significant enough to produce symptoms of hypocalcemia. Glucagon-stimulated calcitonin release can cause hypocalcemia, and there might even be a decrease in the parathyroid hormone secretion that plays a role in hypocalcemia. In saponification, where you have the digested fats acting as a sponge, you have release of retroperitoneal fat by lipase digestion, which sucks up the calcium, and you can also have that calcium sequestered by fat in the peritoneum. When the calcium levels are low, seriously low, this is probably an indicator of severe disease. Hypomagnesemia. We know that hypomagnesemia is not an uncommon finding in people who drink alcohol, both because of potential nutritional deficits and also because of the way that the kidneys manage magnesium. But in acute pancreatitis, there's also sequestering that goes on. The magnesemia is drawn into specific tissues. Hyperkalemia can occur because of tissue necrosis and metabolic acidosis. Remember that when there's a metabolic acidosis, potassium moves from inside the cell out into the serum. This is a picture of saponification. What you see here, here's the pancreas, okay? And the duodenum kind of encompasses the head of the pancreas here. See these chalky white areas? That is where calcium is interacted with fatty acids. Those fatty acids were derived from the breakdown of fat by the pancreatic lipases. That's that saponification thing. You can also see red areas here These represent hemorrhages due to rupture of vessels that are destroyed by the elastases in the pancreas. Hematocrit. Maybe it's elevated if the patient's very dehydrated and they're not bleeding, or maybe it's decreased in a hemorrhagic pancreatitis. Leukocytosis may be elevated, indicating an inflammatory response, not necessarily an infection. The liver function studies are generally normal. The bilirubin might be a little bit elevated if there's jaundice. So generally the liver function studies are normal, unless there's biliary dysfunction that goes along with this. It does happen sometimes, but generally not. Abdominal x-rays or ultrasounds can isolate dilation of a part of the intestine due to an ileus. It may show gallstones. So, the abdominal x-rays are not going to be very specific for the pancreatitis, but pancreatitis can make a patient sick enough to cause their intestines not to work. A CAT scan, that's going to be a better tool for diagnosing pancreatitis. It will show the inflammation. It's best done with both oral and IV contrast. They can do an endoscopic ultrasound also, and then the magnetic resonance cholangiopancreatography. If it's normal, you will not see bile ducts. They set up these sequences to kind of view the no-flow states, so it helps to identify if there's obstruction as a cause of the pancreatitis. It'll show stones or obstruction. CAT scan is the better tool. All right, I'm going to stop, and the next one we'll start with complications.